Good morning, friends and colleagues. Today we have a lecture on A to Z about BCL2 inhibitors. And the guest speaker is Dr. Abhishek Kakru from Ahmedabad. This webinar is brought to you by Mumbai Hematology Group, supported by RPG, managed by Perfect Square. I thank Mr. Ajit Mule, Mr. Sudhir Ambekar and the team from RPG, Mr. Kalpesh, Mr. Yash and their team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Roshan Pandey, hematologist, medical oncologist from Jabalpur, our guest speaker, Dr. Abhishek Kakru, medical oncologist, hematologist from Ahmedabad, all our discussants who are themselves eminent hematologists and medical oncologists, and you participants for sparing your Sunday morning or Sunday afternoon or evening, depending upon which part of the world you are. We have today registrations from over 20 countries. To give you a view of what is coming in the next week, we have 3 webinars. On Thursday, from 8 o'clock in the evening, we have a webinar on romiplastin-based treatment of ITP and beyond. On Saturday, Dr. Binod Dhakal from Milwaukee, US will be speaking on all that you must know about high-risk myeloma, and this will be at 7 p.m. onwards. And lastly, on Sunday morning from 11:30 a.m., Dr. Suma TL from Department of Pediatric Oncology at HCG Hospital, Bangalore will be speaking on management of infantile acute lymphoblastic leukemia. So that's your menu for the next week. And now the discussants for the day. And we've got some fantastic people with us to discuss with Dr. Abhishek Kakru. We have Dr. Abhishek Dudatra from HCG, Ahmedabad. Dr. Adwaita Gore from Prince Ali Khan Hospital, Reliance Hospital, Mumbai. Dr. Aishwarya Raj from GCRI, Ahmedabad. Dr. Ankit Rayani from Cure Hematology Clinic, Ahmedabad. Lieutenant Colonel Dr. Ashok Meshram from INHS Aswini, Mumbai. Dr. Ghanshyam Biswas from Sparsh Hospital, Bhubaneswar. Dr. Jatin Sarin from Chandigarh Cancer and Diagnostic Center, Chandigarh. Dr. Kajal Shah from Apollo Hospitals, Ahmedabad. Dr. Meet Kumar from Fortis, Gurugram. Dr. Nishad Dakate from HCG, Nagpur. Dr. Pankaj Tantia from Acharya Tulsi Regional Cancer Center, Bikaner. Dr. Rahul Arora from HCG, Nagpur. Dr. Sanket Shah from HOC Vedanta, Ahmedabad. Dr. Stalin Bala Chaudhary from Nizams, Hyderabad. Lieutenant Colonel Dr. Uday Yanamandra from AFMC, Pune. And Dr. Yoga Lakshmi from Sir Gangaram Hospital, New Delhi. It's my privilege to invite our special guest for the day who is going to inaugurate our webinar, and that is none other than Dr. Roshni Pandey from Jabalpur. She doesn't require introduction, but I have to do the formalities. She is consultant medical oncologist at Mahakoshal Hospital, Jabalpur. With a view to serve rural India, she opted for doing MBBS from Mahatma Gandhi Institute of Medical Sciences, Sevagram, over Grant Medical College, Mumbai. After this, she did DNB in pediatrics from Apollo Hospital, Chennai. Subsequently, she worked for 1 year in HIV clinic at Vijayawada Hospital for Children, Mumbai. She was NCI fellow at Tata Memorial Hospital, Mumbai in 2000. Her first connection with Mumbai Hematology Group was in the form of participation for Dr. J.C. Patel Best Paper Award session in year 2000. She did residency in pediatric oncology at TMH, Mumbai. However, she was convinced by the stalwarts to complete a rotation in adult oncology. She got trained in clinical trial methodologies as well. She has numerous publications and has presented numerous papers at national, international level. She is recipient of award at CIOP. From 2004 onwards, she occupied faculty position in the Department of Medical Oncology at Tata Memorial Hospital as pediatric oncologist and BMT physician. After getting married in 2006, she moved to Jabalpur. Since then, she has been practicing as a consultant medical oncologist at Mahakoshal Hospital as a certified medical oncologist. Her areas of interest are hematolymphoid malignancies and pediatric cancers. Despite all the challenges faced in this part of the country, her goal has been to reach out to poor patients, guide them through their treatment at the medical college, and provide them accurate diagnosis and offer them standard of care. Dr. Roshni Pandey, I invite you to inaugurate our today's webinar and give us some words of wisdom. Over to you.
Good morning, respected Dr. M.B. Agarwal, sir, teachers and friends. It is my proud privilege to be with all of you today. The calling of hemato-oncology requires a combination of intellect, a strong base in internal medicine and or pediatrics, knowledge of precision medicine, an agile mind, a strong intuition and compassion. This field is like a mission, both demanding and requires commitment. The branch is exhaustive and ever-changing. The recent advances can sometimes be so overwhelming, so do keep in touch with academics despite your busy schedule and draw from the experiences from others. This helps to treat patients more easily, adequately, and avoids over-treatment. Wherever possible, publish and share your experiences with others. It is important to be transparent with patients and their families. Try to build a relationship based on trust. No matter how famous you may be.
Roshni, you got muted.
In doubt, take help from seniors. We have some excellent teachers and colleagues who are always ready to share their knowledge and experiences. If a patient cannot take treatment with you due to finances or logistics, look for another colleague to help them out. Treatment should neither be delayed nor denied. In middle income and low income countries, abandonment is still a major concern. Though India has excellent patient load and experienced teachers, sometimes due to the heavy workload, we forget to understand the basics. So if one gets an opportunity to spend some time abroad, it would definitely change one's perspective. An algorithm-based approach, how to be meticulous, how to talk to patients, record and data keeping, and research methodology are some of the things to emulate from abroad. But do return to your countries. Your bright minds and soft skills are much needed here. For the students of medical oncology, learn to see your own slides. Dr. S.H. Advani sir always encouraged us to spend time in the hematology lab. The Tier 2 and Tier 3 cities lack pathologists trained adequately in hematology. The medical field is one career where students find it difficult to cope due to the exhaustive curriculum, the workload, and the long strenuous hours. So while taking care of your patients, do take care of yourselves too. Don't burn out. Restore your balance with some fun time and friends to be able to contribute longer in life. Have a support system in place. For my women friends, since you are multitasking, an institution-based practice or a group practice is preferable wherever possible to be able to cope up with the demands of a busy career and family. Treat your colleagues with respect. We may not agree with each other always, but we must always protect each other and stand up for one another. I wish you all the very best in life. Realize your own potential. Only the sky is your limit. There should be only one goal for all of us, to ensure that our intellectual efforts are directed towards the relief of human suffering. It has been so rightly said that not all angels have wings, some have stethoscopes. I end by quoting Sir William Osler. The good physician treats the disease, but the great physician treats the patient. Thank you so much, sir.
Thank you, Dr. for those lovely words and inaugurating our webinar. Your sentiments for taking care of the poorest of the poor They're obvious from your CV as well as from the speech today. Don't burn yourself out was a masterstroke statement. And I think both youngsters and seniors will remember that statement. Thank you so much for sparing your valuable time and being with us. I'll just share my screen. Move on now to the quiz for the Sunday. Remember, this quiz is not only for the postgraduate students, it is for one and all. Whatever is your answer, email it to mbagarwal1@gmail.com. mbagarwal1@gmail.com. The prize winner will be the one who sends the correct answer and who is first one to send the correct answer. That is fastest finger first. So now we will go to the quiz. So I'll tell you a story. There's a 70-year-old man. Complains of fatigue and body pain for 3 months. MRI shows osteonecrosis of right humerus and right femur. The bone marrow examination helped in diagnosing an autosomal recessive disease, which has the characteristics shown on the right side. And these characteristics are that whatever was seen in the bone marrow, that disease is characterized by anemia, thrombocytopenia, splenomegaly, platelet dysfunction, coagulopathies, gammopathy, myeloma, and other hematological malignancies. So it's not that this gentleman of 70-year-old had all this, but these are the characteristics which can be found in the disease which this 70-year-old man had. So what is the disease that this gentleman has? The name of that disease, as accurately as possible, is to be emailed to mbagarwal1@gmail.com. And I'm going to keep this slide on for a few seconds for you to keep watching and reading it before you carefully send your entry. So 70-year-old man, fatigue, body pain, 3 months. Osteonecrosis of humerus and femur. Bone marrow gave the diagnosis, and the disease that he has often has one or more of these characteristics put in this circle. What's your diagnosis? Just give the diagnosis as accurately as possible. Okay. So after the lecture, we'll give you the answer, declare the name of the winner. Winner will be the one who forwards the correct answer, fastest finger first. We now come to our weekly case profile. And this is a very, very exciting case that I'm going to show you. We are going to see a case of R. Lone. R-L-O-N. This is a 28-year-old woman who presented with malaise, fatigue, and fever of 3 days duration. She has history of multiple sclerosis, for which she has been on maintenance rituximab therapy every 6 months, the dose of 1 gram. Her last rituximab infusion was 4 months ago. At this admission, she is febrile. There are no other physical findings. Lab shows severe neutropenia with a total white cell count of 1,200 and absolute neutrophil count of 100. Hemoglobin and platelet normal. A diagnosis of R. Lone, that is rituximab induced late onset neutropenia, was made. She received GCSF for 2 days together with other antibiotics and vitamins. And on day 3, her WBC as well as the ANC normalized. The neurologist was advised to use some other alternative medication for her future treatment of multiple sclerosis. Rituximab is used like water by hematologists and oncologists, but we have to remember the adverse events. The acute ones, the immediate ones are well known to everybody, and you take care of that. Infusional toxicity, lymphopenia, infections, and asthenia. Equally important are the late onset or delayed adverse effects, of which hepatitis B reactivation is well remembered. Everybody screens for it, and if required, treats for it. Rarely you'll end up with these three complications: interstitial pneumonitis, progressive multifocal leukoencephalopathy, and rituximab-induced late onset neutropenia, what is called R-lone. All these three are rare, and therefore all these three are forgotten, and all three occur later on in the life. As hematologists, medical oncologists, you know the grading of neutropenia. The grade 3 is something below 1000, grade 4 is below 500. R-lone is defined as unexplained grade 3 or more neutropenia occurring at least 3 or 4 weeks after rituximab infusion. This is very important, because when you give RCVP or BR or RCHOP or whatever, the nadir of neutropenia occurs on day 10. So this has to be after day 20 to consider that this is R-lone. And this can happen not only on day 20 or day 30, it can happen after 1, 2, 3, 4, 5 months. As you saw in our lady, it occurred after 4 months. Rituximab is now used not only in oncology and hematology, it is used left and right by rheumatologists and neurologists. R-lone can appear irrespective of the primary diagnosis, whether it is a cancer, whether it is ITP, whether it is SLE, or whether it is multiple sclerosis. There is a literature review by Hinks et al., which is a meta-analysis of 9 studies on 92 patients who developed R-lone. And they showed that all except one, that means 91 out of 92, fully recovered with a normal ANC. The study on R-lone in rheumatological disorders showed highest incidence in Wegener's and SLE, 23% and 20%, which is 1 out of every 5 or 1 out of every 4. This is one of the highest incidence, as against rheumatoid arthritis, where it was just 3%. We do not know the reason for this. None of the studies found a predictive factor for development of R-lone. So it's impossible for you to know who will develop this complication and who will not. Even the exact mechanism besides late onset neutropenia is unknown. Findings that have been published include significant B lymphocyte depletion and a decrease in S immunoglobulin M level as against controls, and the P values were significant. The suggested mechanisms include production of anti-neutrophil antibodies, expansion of large granular lymphocytic cells, and aberrant B cell reconstitution. There is very recently IgG FcGR3A polymorphism at the site 158 V/F has been found to be highly associated with the development of R-lone, and this has been now multiply quoted. This is a nice cartoon showing you the mechanism proposed or shown of this entity lone. So immunological or hematopoietic disturbances, antibody mediated, cell mediated, transcriptional like maturation arrest, or infections, published in 2003, 2008, 2006, and so on. Hematopoietic disturbances, growth and retention factors, B cell depletion, bone marrow fatigue, genetic factors like SNPs in Fc gamma receptors, BAF promoters, underlying diagnosis are some unknown factors. Again, published over last 2 decades. Rituximab can cause a delayed and late onset neutropenia that may last for an unpredictable amount of time. Although most cases appear to be self-limiting and resolve without any important issues, R alone may result in serious life-threatening complications needing immediate medical intervention. When patients with autoimmune diseases or cancers are treated with rituximab, it is important to remember this entity long beyond the therapy cessation. This adverse event can pose a challenge for clinicians and requires close patient follow-up during as well as after the therapy. Given the unclear nature and the mechanism of R-alone, it is not clear whether retreatment with rituximab is a viable and safe option. It has been previously reported that re-challenging a patient with rituximab can lead to recurrent episodes. With this possibility of recurrence and unclear risk and implications of retreatment, the decision to administer further dose should be based on case-to-case basis, and future research is definitely needed in this area. I must thank Dr. Vibhor Pardasani, our neurophysician at Bombay Hospital, for involving my team in the management of this patient. And he is a senior neurophysician with us, and this is his first case of this entity in his patient of multiple sclerosis. That speaks about that the entity is rare. Now we come to the main part of our today's webinar, and that is we go to our guest speaker, Dr. Abhishek Kakru. He has been our speaker during this pandemic in past. He's also been our speaker for many meetings in Mumbai and Ahmedabad, and he is a wanted speaker from all across the country. He speaks beautifully. He does hard work in presenting the data, and that is what one appreciates. And today will be nothing less. You will learn all about the subject that he's going to cover. He's consultant medical oncologist and hematologist at the Hemato-Oncology Clinic at Vedanta Institute of Medical Sciences, Ahmedabad. He completed his DM in medical oncology from GCR Ahmedabad way back in 2009. He underwent training in hematopoietic stem cell transplantation at the same institution. His areas of expertise include hemato-oncology and the stem cell transplantation. He's going to lecture us today on A to Z about BCL2 inhibitors. I'll stop here and request him to take over.
Thank you, sir. Thank you very much for those kind words. You have been always very kind. So, good afternoon, everyone. And thanks, first of all, for joining us on Sunday afternoon, sparing your time. Everyone is possibly waiting for their families to have lunch, but very kind of you to spare a few hours for this lecture. And I think the credit goes to Dr. Agarwal. Some of the best people in world have spoken on this platform, and I think I'm very privileged for the same. Can you see the slides?
Yes.
Okay, so let me start.
Full screen mode.
Yeah.
Done.
You can hear me. I'm audible, right?
Yes.
Thank you, sir. So this platform is so good that whenever sir asks me to speak, I am just lost for ideas that what should I speak. So every time I have to tell him, you give me the idea, because I have no clue what to speak, because possibly everybody in the world who of the hemato-oncology has spoken and such great topics have been discussed. So sir came with the idea of BCL2 inhibitors, and no wonder sir is very knowledgeable. When I went in depth about this topic, I realized possibly this drug looks like the future of hemonc in some ways. So it has been there since very long, but now it is picking up. So before you go into BCL2 inhibitors, it is very important that we realize what these guys are up to, and what is BCL up to, and what is BCL2. So if we are clear about the physiology, as our masters used to always say, you should be very meticulous with your guidance. So if you know the physiology, you know medicine, and you know then everything. So let us see. So basically, what BCL2 and this group of proteins, it's not just BCL2, it's a gang of proteins which are involved in what we call as apoptosis. So apoptosis, if you just ask anybody, he would tell you it is a suicide of the cell or a programmed cell death. Or whenever the cell loses its will to survive, generally breaks off and is eaten off by the phagocytes, which is called apoptosis, and it has been taken from a Greek word that we all know. We have learned this definition, meaning falling off. So next thing was to look at the pathway of apoptosis. So when I looked at cell signaling, so this is what came up. This looks like more of a traffic signal of Mumbai or Ahmedabad. It's utter chaos. So when I looked at this, I said, this topic looks impossible, nothing doing. But believe me, amongst this chaos is a mutual understanding and a great network of nucleic acid, proteins, and cell signaling pathways, which ultimately controls the cell's fate. And we'll do just a simple basic dissection of this. Nothing, we are not going through everything on this picture. This looks like chaos, but in this chaos, what you need to understand is what is apoptosis. So whenever a cell loses either intrinsically, if today we are talking about oncology, hemonc. So if there is a DNA damage, so we are using PARP inhibitors now commonly in oncology, leads to DNA damage. So if the cell's DNA is damaged internally, or if the extrinsic factors like a BTK inhibitor. So let us take CLL, and the BTK would inhibit the BCR signaling. So the cell would lose its signals to survive. Whenever that happens, either intrinsically or extrinsically, the target for all of these is this BCL group of proteins, because it's a heads and tails between these group of proteins, which ultimately leads to the fate of the particular cell we are talking about. So if you can see intrinsically or extrinsically, whenever the factors are there which promote cell death, the BCL2 is in the center of the action. And what happens is, this is from a very good paper from ASH. In the there was a I'll give you the reference in the last part of my slide. A couple of very good papers in ASH last year and even before that, which spoke about BCL2 inhibitors. And simply, if you see the red dots, you can realize that BCL2 is in the thick of the action. Basically, BCL2 prevents apoptosis. It prevents the cell death. And what happens is, whenever there is an extrinsic or an intrinsic reason for the cell to die, this BCL2 is inhibited. And this BCL2 is inhibited by the you can say it's the other half of the same group of proteins which are involved in killing the cell or causing the apoptosis. So the BH3 would inhibit the BCL2, and once the BCL2 is inhibited, I'll tell you what happens. So what has happened is, the stimulus is there, or the stimulus is lost, so cell is supposed to die. BH3 blocks the BCL2. So remember this, I have highlighted these proteins because these are going to come up regularly when you think about apoptosis and BCL2. So as I told you, these are a group of proteins. It's like a team, India-Pakistan team. They are fighting against each other for the cell survival. So you have an anti-apoptotic, which we all know as BCL2, but the two important ones are BCL-XL and MCL1. These three you need to remember. The reason is, maybe in the future, not very distant future, you will have inhibitors for MCL1 as well. So why these three are important is because if you block all of these three, that is one reason why the first generation of anti-apoptotic drugs had a lot of side effects. And where venetoclax, our today's hero, scores is that it is a selective BCL2 inhibitor. It has very minimal effect on the other two anti-apoptotic proteins. And what are the counterparts which are fighting for apoptosis or causing the damage? You can see the pro-apoptotic one. Basically, it is called the BH3 group of proteins, which you have the BAD, BAX, BIM, PUMA, NOXA. So we are not talking about all of them. So what happens? As I just told you, once the BCL2 is inhibited by a BH3 mimetic drug, which is a venetoclax or whatever. So you can see from this figure, the BCL2, which is the anti-apoptotic. Why it is anti-apoptotic? Because it has caught hold of the pro-apoptotic proteins. So it is basically has caught hold of BIM, which is the trigger for the apoptosis. And once the venetoclax has caught hold of the groove, where this protein is basically attached to BCL2, the BIM is released. You can see in the middle part of the slide, when the venetoclax is there, the BIM is released. And once the BIM is released, what it does, it basically leads to oligomerization of all these proteins, the pro-apoptotic proteins, which lead to cytochrome C released from the mitochondrial membrane. So a channel is produced. This channel leads to the release of cytochrome C, and whenever cytochrome C is released, it basically signals the end of, it signals death or end of the cell. So what happens is then cytochrome C, you can see again, I have highlighted the middle part of the diagram so that it can be easy for you. It activates caspases. So again, details probably are out of our reach. Caspases are about 12 to 14 proteins or nucleic acids again present within the cell, and they make sure that the DNA and the cell is broken off into smaller bodies, which we call as apoptotic bodies, and eventually they are eaten up by the phagocytes. So this is a programmed cell death we are talking about, which is apoptosis. And you realized where BCL2 fits in and where venetoclax fits in. Again, the same thing. If I have to put it again, you summarize it again. BCL2 is there. Whenever the signals are lost and the cell is supposed to die, BCL2 is inhibited by BH3. So BH3 is what? It's our venetoclax. And that is the drug we are talking about today. It's called a BH3 mimetic drug, or something which is resembling BH3. And once the BCL2 is inhibited, you saw the mitochondrial membrane, the downstream proteins are channelized to release cytochrome C, which leads to caspase activation and ultimately leads to the cell is broken off and it is ultimately just eaten up. So this is the BCL2 inhibitor we are talking about, which is venetoclax. They have been post several BCL2 inhibitors, but the marketed drug is venetoclax as of today. And as the slide is showing you, there is clinical activity. We are talking about CLL, AML, myeloma. It has activity in some other lymphomas as well. I will not talk about PL and BPCN because it's very rare, but we'll talk about the common indications later on. So again, rephrasing, what is BCL2? BCL2 is B-cell lymphoma 2. Basically, as you just realized from the diagrams, it regulates apoptosis, or it's basically a balance between the two group of proteins, the BH3 and the BCL2, which controls cell death. What has happened is that it is highly expressed in some of the hematolymphoid malignancies, especially CLL, which tells us that the cell survival is promoted by the high expression. So what will high expression of BCL2 is basically, it will prevent the cell from dying. And if it prevents the cell from dying, you can be sure that the tumor will grow or the cells will proliferate, which is what happens is on leukemias and many hematolymphoid malignancies. In fact, it would happen in most malignancies. So this would be a common pathway for most cancers, not just hematolymphoid malignancies. So why is venetoclax special? As I had told you, remember the 3 BCL proteins, which is BCL2, XL, and MCL1. So BCL2 inhibits, the venetoclax inhibits BCL2 in very, very, very small concentrations, picomolar concentrations, and it exhibits 100-fold more selectivity to BCL2 compared to BCL-XL and 1,000-fold compared to MCL1. So it's, you can say, it's as selective for BCL2 as is possible. Its previous predecessors. So you can see the BCL2, BCL-XL, and MCL1. As I told you, the green guys are in line, and already the trials are going on for another group of anti-apoptotic drugs, just like venetoclax, which would be an MCL1 inhibitor. Because one of the reasons is that BCL2 inhibitors, ultimately their use leads to resistance and upregulation of MCL1, which is one of the escape mechanisms for resistance to, or resistance mechanism to venetoclax. So there is already work which has been done on MCL1 inhibitors, and the phase 1-2 trials are already there. So as you can see, the venetoclax is there only on BCL2. There have been navitoclax and other anti-apoptotic drugs which probably work on a wider spectrum, causing a lot of side effects. So they generally basically just disappeared from the screen, and venetoclax prevailed. So what is a couple of slides when we are talking about physiology? So about BCL2 inhibitors, probably this is the most important slide after the ASH figure of how BCL2 works. So if you remember this, you will realize where this drug should work, how this drug should work, and how we should use it. So you can see this diagram. It's a very simple diagram. It will tell you everything. So you can see from the left side, there are tumors which are BCL2 dependent, highly BCL2 dependent. So it's a bullseye effect. The arrow is at the center of the bullseye. And there are tumors on the right side of the slide, you can see, which are partially dependent. They don't fully depend on BCL2, as would be the case of many malignancies. So it's not one pathway. There are multiple pathways working. So if you are partially dependent, the BCL2 inhibitors might not be the same great as it would be for a BCL2 dependent tumors, but they could be of assistance. So let us see. So your bullseye effect, we take an example on this side of the spectrum, you have CLL. So it has a high percentage of BCL2 dependence and low percentage of the other MCL1, BCLXL. So in CLL, this drug has worked wonders. On the other hand of the spectrum is like your DLBCL, your double hit or triple hit lymphomas. So BCL2 expression, we all know BCL2 and BCL6 are expressed in double hit lymphomas, but possibly they are not the only mechanisms or highly expressed. So in DLBCL, we are still struggling for response, or we are still struggling to make a combination which would help us use, as in the case of CLL for venetoclax. And in the middle of the spectrum, so this is where the entire field is working. Middle of the spectrum is somewhere between your partially dependent, fully dependent are your lymphomas, myelomas, and the AML. And there is where the scope is using the correct combination of medicines together with venetoclax, so that the toxicity as well as the safety prevails and the effectiveness of our chemotherapy medicines or targeted medicines is much improved, leading to better responses and survival. So if you know which tumors are highly dependent, probably even if the you do not have the approvals, there is you have a lot of relapse refractory cases where you might have some merit of using this drug. So let us come. Another very important physiology you should remember is your ibrutinib, your BTK inhibitors, as I had previously told you. So the B cell receptor signaling from the outside is stopped. The BTK inhibitors works from there, and your BCL2 inhibitors basically works on BCL2, which is within the cell. So very important. The two work in a very good synergistic way. One is working from the outside. Ultimately, when the signaling stops, it also leads to apoptosis. And your venetoclax directly works on BCL2 with the help of BH3, and it is causing the apoptosis. So they both add on to their effect synergistically, and that is why the combination of the two has worked wonders in CLL. So again, a bit of information which you should remember. So what has been the journey of our possibly only BCL2 inhibitor which we are using today in our clinical practice? So it was, the approval was first filed in 2010, a patent was filed in 2013, October it was approved. 16, the first approval came in relapse refractory cases with 17p deletions, so your bad CLLs. It worked very well. So 2018 June, it received approval in relapse refractory CLL irrespective of 17p. So first it was approved in 17p, then it was approved irrespective of 17p, and lastly in May 2019, it was approved in first line, it was approved in relapse, it was approved in all cases of CLL. In addition to its other indication, in 2018, you can see the approval was given for adults or senior citizens with myeloid leukemias, where your conventional chemotherapy could not be used. So you used it with the help of your HMAs and low-dose cytarabine. So this has been the journey so far. In addition to this, there have been several other small nascent approvals for venetoclax. We'll see that later on. So a word about all the pharmacokinetics or dynamics of this drug. So you know the original brand is Venclexta, and we commonly used to, when you used to read about it before it got the approval, it used to be known by the ABT 9199. What is it? It's, as I told you, it's an anti-neoplastic drug. The class is called BH3 mimetic drug. Directly acts on the cell. The mechanism action is clear. There's no other way. Directly acts on the cell together or with the help of co-drugs like ibrutinib, it would cause a cell death or apoptosis. Important word about the two highlighted ones, the pharmacokinetics, maximum plasma concentration is reached in 5 to 8 hours. An estimated terminal half-life is more than a day, about 26 hours. Most common side effects, as would be expected, is cytopenia, neutropenia, anemia, thrombocytopenia, diarrhea, your infections because it could lead to fetal neutropenias. And of course, very important is tumor lysis syndrome. So this is something about the drug itself. If in a screenshot, I have to go through all the data we have as of today for venetoclax. Again, I would quote the same ASH publication from last year, which you can see I have highlighted what is important for you. So this basically tells you in CLL relapse cases, CLL first line cases, single agent, there was some usefulness. The response rate was about 80%. The median PFS was 25 months. But the main data was in the first line cases when it was used with a CD20 inhibitor or an ibrutinib, where you had excellent 1 year and 2 year survival in the range of 90% and beyond. Similarly, AML relapse refractory first line or even single agents, you saw some modest activity, nothing great. But when it was used in combination with with a HMA inhibitor like a decitabine or azacitidine in low dose Ara-C, your median OS, which was hardly 26 to 10 months, went over to 15 months, and responses were doubled. So this is basically, again, if you have to talk about lymphomas, so it was used in follicular lymphomas. Single agent activity was modest. Mantle cell lymphoma, again, diffuse large, single agent activity was modest, but in combination with ibrutinib in mantle cell lymphoma, you can see the responses are beyond 70%. There are some good CRs and PFS around 30 months. So it has been approved in relapsed mantle cell lymphoma. Even DLBCL, it was tried, as I'll tell you later on, but there were problems with the trial. Follicular lymphoma, there were some modest responses in combination, but has not been approved. What about myeloma? So myeloma, it did show a PFS advantage, but there was no overall survival advantage. Single agent activity was very modest. And what happened is, in a certain specific subset of patients, it did show a very beautiful response. So that will come to. If you have to just highlight where the approved, these are the landmark 3 trials where the approvals came from. So that was all the data of venetoclax. What about the landmark trials? So CLL relapse, we have the approval, which is the venrituximab compared to your chemotherapy. You can see the 3-year PFS is more than 5 times. What about first line? You can see compared to your traditional chemo, your radioimmuno RIT. So what has happened is Ven-Obino has improved your PFS. Although the improvement in the OS has been very modest, but it has been approved in the first line, especially in elderly infirm patients with a lot of comorbidities. What about AML? You can see the OS has doubled in both the landmark trials, which compared low dose Ara-C versus Ven compared to placebo, and your HMA versus placebo with Ven. You can see the OS has gone from 9 months to 15 months. And in the AML first line, which was previously treated with low dose Ara-C, it has gone from 4 to 8 months. So this has led to the approval. These are the trials which led to the approval of venetoclax. So let us go in some small details about the approvals which we have and what the future holds for BCL2 inhibitors. So you would wonder, I have started with AML instead of CLL. So CLL is possibly the best indication for a venetoclax, but what I find is clinically we use venetoclax more in AML rather than in CML. I hardly see patients on venetoclax in CLL, and most of our elderly leukemias are on AMLs, or even MDSs are on HMA with a venetoclax, which is very commonly used. So I thought we should start with AML, because clinically I find AML is a preferred indication for most of us. So if you have to put the treatment of ALL, I won't go through it. What the left part of it is important: not eligible for intensive chemotherapy, which is the indication where venetoclax is. And as you can see, with your low dose Ara-C, with your HMA, venetoclax is approved in all patients. The challenge is, and already the trials are there, if you have a mutation like an IDH1, FLT3, do you add the third drug? So can triplets be allowed? So the work is already there. The data is very exciting. So let us look as to how we reach this place. Again, the NCCN guidelines would tell you the same thing: venetoclax with an azacitidine, venetoclax with a decitabine, venetoclax with a low dose Ara-C. So it is there. So till now, where did we stand? So we elderly AML, more than 60 years of it, difficult to treat, very few CRs. We are not expecting CRs, and a median survival which was dismal, 6 to 10 months, even with the best of the drugs. And obviously we are not using the conventional high dose chemotherapy. What venetoclax did is, this is the VALE trial where azacitidine with placebo was compared to aza with venetoclax. I'm very sure you are aware of this trial. And what is important is the median PFS. As I've told you, as a rule, if you consider the median PFS was anywhere from 6 to 10 months, has gone to beyond 14 months with the addition of venetoclax with tolerable safety profile. Again, the C part of it with low dose Ara-C, you can see the median OS has improved from 4 to 7 months, and additional 6 months of data is shown. Again, the same thing. So median OS has doubled with the addition of venetoclax to low dose Ara-C. Important thing is how it is done. So you can see from this side, venetoclax was added to an HMA. Obviously, the rule with venetoclax is you take it with food and water approximately at the same time each day. Do not swallow, crush, or break it, and you ramp it up. So day 1, 100, day 2, 200, day 3, 400, and then we continue. And together with that, you have an HMA in the form of AZA in the standard doses or decitabine. In low dose era, the reason for putting up this slide is the low dose era C, the difference was that the ramp up was still 600, or you could go beyond with a low dose era C of 20 milligram meter square from day 1 to 10. And if you summarize the entire data, venetoclax with a hypomethylating agent or an HMA in an unfit AML patient, you can see your AZA has a 2-year OS of 20%, same with decitabine, probably more lesser than that. But what your venetoclax with HMA did is your CRs improved from, basically it was more than doubled. Median PFS, as I told you, from a meager 6 to 10 months, it went to beyond 14, 15 months. And 2-year OS was from less than 20% reached to more than double. So it was around 40 to 46%. So that is why it was recommended and has been approved in elderly unfit AML. An interesting publication from the last year's ASH as well as Blood. So I have broken up this presentation according to the indication. But what is interesting is where the field is going is they are trying to find out biomarkers when venetoclax could work even better rather than just using it in a broad sense in every patient. So this is a biomarker driven analysis of the same trial. So you can see I have highlighted just 2 parts of it. There are 2 biomarkers. We are talking about AML. There are several biomarkers. We will talk about just 2. An IDH1/2 mutant elderly AML, where you are using your HMAs with venetoclax, you can see the CRs are more than double. If IDH1 has mutated, the CR has gone from 34 to 64%. The CRs have improved, the OS has improved. So the drug is working better in this class of drug. Your TP53 mutant, again, the CRs have improved. The OS may not have improved, but the CRs have improved. Obviously not, if you put a patient without TP53 mutation, he would do wonderfully well compared to a one with TP53 mutation. But if you consider just AZA, single agent, then AZA with Ven was doing much better than just AZA. So again, you can see from this forest plot, IDH1/2 mutant, your TP53, even your NPM1 and FLT3. So AZA plus venetoclax was doing far better than AZA plus placebo. And especially why I have highlighted IDH1/2 because it was doing extremely well. See, you can see from this slide, this is the subset analysis from the same data where IDH1/2 patients were selected out of it. And you can see the CRs are 70% and beyond compared to 7%. Duration of response is from 14 months, we are now looking at 30 months. And the median OS from 6 months, we are looking at 24, 25 months. So possibly this group of patients fare far better than your conventional all patients together. It's giving you a subset of patients where you can target, possibly use this drug much more judiciously. And even in the other subsets, as I just showed you, it was doing better than single agent azacitidine. Obviously, there was not an overall survival advantage. The IDH1/2 guys definitely had an overall survival advantage. So this is one subset analysis or a biomarker driven analysis of venetoclax that was done. What about the future? So again, this is a abstract from ASH 2021 where venetoclax was added to FLAG-IDA. So this is your AML fit patients where you are using your conventional high dose chemo, and while you are using venetoclax, you are trying to induce deeper responses. And amazingly, the 30-day and 60-day mortality, no mortality occurred. So it's working well. The neutropenia, obviously pneumonia, and the side effects were there. But what I've highlighted is you can see the 12-month OS and the 24-month OS. It's 96% at 12 months and 87% at 24 months. This is abstract. It's not a huge trial. It has to be taken with a pinch of salt, but food for thought. So venetoclax, and even in this, the IDH1/2 guys and NPM guys, which were very small, 13 patients, but they did experience an 18-month survival of 100%. So you can see venetoclax is picking out picking out some subsets where it is doing extremely well compared to others. So food for thought. I think it has to be, the science is progressing in a better way. What about CLL? So CLL is where our hero is working the best. So if I have to broadly put up CLL, this is what is recommended. We all know this. if you highlight, it's either a CD20 with a BTK, it's a BTK alone, it's a CD20 with a BCL2 inhibitor, venetoclax, and the only subset where you have chemo left possibly is your IGVH mutated guys, very fit young patients where you might still think of an FCR, but I doubt that will prevail for a very long time, because even in those guys, the combination of ibrutinib, venetoclax, or all of these non-chemotherapeutic agents are doing far better than your just chemoimmunotherapy. So basically, if I have to summarize, this is a flowchart of the treatment of CLL, but it's BTK or BCL2 with a CD20 as of today. So I don't think we should get frustrated with the complication of this slide. The treatment is very simple now. So before we start the discussion about CLL, very important thing is what BCL2 has done to this entire field, especially in CLL. So it's like BTK inhibitor or ibrutinib was the hero. I remember sir taking lectures about ibrutinib, and he was very sure that this is the future of CLL and maybe other leukemias as well. Yes, so BTK inhibitor, obviously it was far better than your chemoimmunotherapy. If you have to compare the two, what BCL2 did is that BTK was good. Starting it was easy. Problem was and it was an indefinite therapy. So you cannot stop the ibrutinib. Concern was that it had some very minimal cardiac and bleeding complications, but that were taken care of by the next generation BTK inhibitors. And obviously you had a favorable data in your poor subsets. So the problem with these BTK was that it's an indefinite therapy. Otherwise, I don't find any problem with a BTK inhibitor. It's a good drug and it has been the standard of care now. What about BCL2? Where it revolutionized the entire thing is, it is a difficult drug, no doubt, cumbersome initiation. There is a problem with TLS, your tumor lysis syndrome. We'll get to that in the last part. And there are some questions people raise about whether you should use it in the high-risk population, but I don't think that prevails, because there is data to suggest that BCL2 inhibitors together with the CD20 or even a ibrutinib would do wonderfully well even in the poor subsets. So where it scores is, there is data for a fixed duration of a BCL2 inhibitor. It's like CML. We started off with imatinib. We used to continue for life. We never thought one day that we will be asking patients to stop treatment. When the second generation and third generation drugs came, now you frequently ask your patients to stop when they are in molecular remission. So basically it revolutionized the entire treatment of CML. And possibly this is what BCL2 inhibitors are doing, because the problem with BTK is that most patients get fatigued with the treatment. Somewhere they have to stop. So this is where BCL2 scores. So let us look at the data. So this is, I told you, BTK with a CD20 in elderly unfit patients, and CLL14 was the trial where venetoclax with the obinutuzumab was compared to a traditional treatment, which was your chlorambucil was obinutuzumab. Obviously, it was no match for your Lukeran. The median PFS, you can see, you can drive a car through those two graphs. It is 35 compared to 74%. HR is 0.33. So 70% of the patients are doing better. And across all molecular subsets, so it would be IGVH mutated guy or TP53 mutated guy, the venetoclax with CD20 was doing better. Again, the same article I'm quoting again, but this is now CLL. So we know that there are three basic molecular markers in CLL, which we all remember, which are the high-risk markers. Your TP53, your deletion 17p, and your unmutated IGVH. So these are the three subsets which are bad. We all know that. So what about the data from all of these trials? Whatever trials we have as of today, your chemoimmuno or your RIT compared to your venetoclax with an anti-CD20 antibody. So what happened is, you can see from the, if you don't go through all the numbers, the conclusions are the CRs and undetectable MRD are far better. The PFS is far better. And obviously it has a prognostic role that even in this, just like BTK, wherever there is 17p, you say ibrutinib. So there is definitely data to suggest that venetoclax is also doing as well, or maybe even better. So in your three bad subjects, the venetoclax with a CD20 is doing better than your conventional chemoimmunotherapy. So there is proof of concept that you could use a venetoclax, you could use an ibrutinib. There are still some reservations where the venetoclax should be used upfront, but there is enough data to suggest that it could be used upfront in the bad subset as well. And this possibly are being used as prognostic or biomarkers for using venetoclax judiciously in particular subsets of patients. So your guys, without this, you might still go for your conventional chemo immuno because cost is an issue in India. But in this bad subsets, just as you explain everybody about ibrutinib, there is data enough to suggest venetoclax. So what happened with venetoclax is, even in the CLL14 trial, is that you can see the topmost part of the graph, the dark green line. So these are the undetectable MRD guys. They are doing extremely well. The line has flattened out even after 4 years. And those guys who did not have a undetectable MRD were doing bad, which is quite expected. So the headache was whether you continue treatment, whether you stop treatment after a definite period of time, and if you stop, then how do you monitor and how do you treat these guys if the MRD becomes detectable? So that was $1 million question, and people are working on that. Again, the same thing. So you can see a large majority of the patients became undetectable MRD or MRD negative compared to just very few who were MRD positive. And the guys with the undetectable MRD were possibly doing very well. They had a flattening out of the curve. What about relapse? So that, as I told you, the treatment is very simple. Don't worry about the slide. You used a BTK with an anti-CD20 or a BTK first, you go to a VEN, either single agent or with a CD20. And if you have used a VEN with a CD20 first, you go to a BTK. The chemo is always there for you. But if you think about treatment, chemotherapy-free treatment, which is possibly the mantra of the decade, avoiding, even in oncology, we are now fans of immunotherapy. So just like that in hematolymphoid, chemotherapy-free management, possibly that is the way in CLL. So if you have used a BTK, go to a VEN. If you have used a VEN, you go to a BTK. You have a PI3K, which is behind there waiting. If these two both fails, the chemoimmunotherapy is always there. So what about relapse? This was the Murano trial where your conventional relapse patient, you would have given a BR, was compared to a VEN rituximab. Again, a fixed duration. The duration of the trial was Venclexta was given for just 2 years. And again, you can see HR is 0.19. So 80% of the patients are doing far, far better. The median PFS was BR for 17 months compared to more than 50 months for VEN-R. Even the 5-year overall survival, you can see the difference. It was far better. What about MRD negativity? Quite a number of these patients became MRD negativity and they had flattened out. So they were doing very well. So that led to the entire concept of MRD directed treatment. As is the case in CML, you have a second leukemia where MRD directed treatment is now possibly the treatment of choice. So before you listen about MRD directed therapy, you must realize this is a summary slide which I've got, which tells you basically of about BTK inhibitors. So BTK inhibitors did show some MRD negativity, but the MRD negativity with ibrutinib based regimes, in all of these 3 main trials of ibrutinib, there was MRD negativity in the range of 5 to 15, 20%, and over a period of time, it did increase to some extent, but the MRD negativity was nowhere near what a venetoclax combination regimes or the combination of venetoclax with ibrutinib can give you. So ibrutinib is a good drug, but it is nowhere close to venetoclax when it comes to MRD negativity. So this was the first, I think this was an investigator-initiated phase 2 trial where ibrutinib with venetoclax was used, where ibrutinib first, I think 3 cycles were ibrutinib, then venetoclax entered. These are elderly patients with all the bad features. What is important is just focus on the green bar. These are bone marrow undetectable MRD guys. And you can see as the cycles are increasing from 3 to 12 to 18, your best MRD negativity is about 75%. Amazing results. Whether this translate into an advantage as far as overall survival goes, that time will tell. But important thing is it's a fixed time bound treatment where you can stop the treatment after you achieve an MRD negativity, and then you follow them up. Again, there's nothing to say. It's a flat line. The ibrutinib with VEN had basically a more than 90% PFS and OS. What about the only phase 3 data as of today, which we have, which is the ibrutinib venetoclax compared to your conventional chlorambucil obinutuzumab in your frontline CLL, the GLOW trial. Again, in this case, your ibrutinib venetoclax was compared to your traditional chemoimmunotherapy in your CLL patients. and there's no comparison because the median PFS was not reached versus 21 months. HR is 0.21. So 80% of the patients were doing far better than most of the other guys. The venetoclax, obinutuzumab, the ibrutinib guys were doing far better than the others. If you can see the right side of your slide, the bone marrow and the peripheral blood MRD negativity, it's beyond 50%, which was like 5, 10, 15% for your ibrutinib only regime. So undetectable MRD was far better in the ibrutinib venetoclax containing arm. This is the Captivate study. This is a phase 2 study, but this is one of the very interesting studies. I had previously discussed this in my last lecture as well, where a fixed duration. Why is it important is because you had taken only a fixed bound treatment of 12 months. So we gave ibrutinib venetoclax for 12 months. Then the patients were frequently asked to do an MRD. Once they were MRD negative at 12 months, they had an option of just stopping, or they had an option of continuing with ibrutinib. Those with a detectable MRD had an option of continuing the combination, which is an ibrutinib venetoclax. So what is important is, you can see at 12 cycles, which is a fixed time-bound duration, at 12 cycles, the peripheral blood and bone marrow MRD negativity, the best responses was beyond 70%, both peripheral blood and bone marrow MRD negative. And at 16 cycles, that rate reached to about more than 90%. It's a phase 2 data, but point is that the MRD negativity was much better with the combination of the two drugs. And as was expected, the PFS and the disease-free survival was excellent. You can see it's practically 100%. Even in the placebo arm, instead of 100, it is 95. So only 5 patients have fallen off, possibly, have become detectable MRD. And if what the right side of the graph tells you is, even those who are MRD positive and we continued the drug with ibrutinib venetoclax, as I told you, at 16 cycle, it was beyond 90%. So another 30% were added to the MRD negative group. So the drug kept working even in the MRD detectable guys, and ultimately that led to MRD negativity. And there was an option of stopping. A fixed amount of treatment was given, and the patient could always go back to observation. And that has possibly led to a armamentarium of trials, a huge number of trials, which are basically looking at fixed combination drugs. So you are looking at now newer generation of drugs being added to the trials. So this is your PI3K. So you might wonder why PI3K is here. But this PI3K inhibitors is highly selective. Your umbrella slip is far better than the other PI3Ks which are there in the market. It is more selective, has very little side effects, and is much more responsive. And it was added to, again, a new antibody with a venetoclax. I won't go through the details, but this pilot study, a phase 2 study, a very small study. But if you focus on the purple bars, the peripheral blood MRD at cycle 12 was 100%. And the bone marrow MRD was almost 80% at 12 months. So we are doing even better now. And that has led to your phase 3. Now, this is the phase 3 trial, which is probably in action, must be recruiting, and you'll have the data in the future. What about there are interesting abstracts which were there in ASH. These are very small phase 2 studies, but food for thought. So people are now combining 3 drugs. So now what about from a single agent ibrutinib, you landed up with the ibrutinib venetoclax, and now people are looking at all the 3. So ibrutinib venetoclax obinutuzumab. So it's a chemo-free regime. There's no problem. I think the tolerance in most of these trials, the tolerance is excellent. Although very small data, you should wait for the final phase 3 data. But you can see in the treatment naive guys and as well as the relapse refractory guys, the response rates are beyond 80%. And the bone marrow and peripheral blood MRD negativity is 60 to 50%. So the triplets without chemo are giving you more than 50% undetectable MRD. So this was the initial data which they pulled off, which was presented in ASH. This is another one, time limited. Again, you have venetoclax, eclabrutinib, and obinutuzumab in treatment naive CLL. And if you have to summarize these slides, so very small 37 patient data. What is important is, if you can see the graphs, the IGVH unmutated, the bad guys, the TP53 mutated, as the drug continued, the patients got better at MRD negativity. Your dark purple is your CRs. So they kept improving as the drug continued. So triplets This is the third one, the bovine trial, the zanubrutinib with venetoclax and obinutuzumab. Just look, it's a small data, 39 patients, but look at the last graph. Peripheral blood MRD negativity and bone marrow MRD negativity is 90%. So we are basically now, that is why I just started my lecture that uh, in CLL, even the FCR, the small subset which we still say needs FCR, might not exist for a very long period. So it would be chemo-free treatment. So problem with CLL is, or what I would call it as intangibles. What you need to decide on day one is when you see a patient, basically it's a problem of plenty. It's like the Indian cricket team. You have a lot of guys, you don't know whom to pick. So what you need to decide on day one is whether you want to give a ibrutinib, which would be an indefinite treatment. The first thing first is, and second thing is whether you want to go in a fixed duration treatment, which is an as of today, it's venetoclax with a CD20, because ibrutinib venetoclax, this is still data is, you are getting the data, but still I would suggest you could use that. So you have a fixed duration versus a indefinite BTK. Second problem would be, if you are looking at the patient, you need to decide whether this guy can go in for the rough venetoclax, because the initiation is rough, as we all know, or the BTK inhibitor is quite smooth. Then the problem would be, third thing, you would decide whether you use a ibrutinib or a acalabrutinib, or a single day dosing or a twice a day daily dosing. Obviously, for a country like India, cost would probably be the first constraint. And last but not the least, you would have to look at patients very carefully whether they are able to tolerate ibrutinib. So your cardiac guys or those with a bleeding tendency might not tolerate that, and somebody with a renal problem would not tolerate a venetoclax, or an elderly, very elderly, infirm patient, although the data is there. So these are questions which you need to answer, possibly discuss with your patients, considering all the pros and cons before starting a fixed duration or an indefinite treatment. So if you just summarize the entire treatment, it's like BTK plus or minus CD20, it's a BCL2 plus or minus CD20, it's a PI3K plus or minus CD20. I won't speak about CIT. The issue is, if you can see the last two lines, the lower two lines, whether you want a continuous treatment or you want a fixed duration treatment, you want a MRD guided treatment, or you just want to continue treatment indefinitely, as we do in our case. Would you go for the conventional thought process, as we have in oncology? You use drugs sequentially, don't give everything upfront. What would you do later on? Use a sequential or a combined regime. So there are several questions which need to be answered. The answers are coming up, and possibly it has to be discussed with the patient before we do anything to these guys. So let us come to the last indication, which is MDS and lymphoma, where venetoclax has been possibly working. So as would be the case for an AML, and high risk MDS is probably just like an AML. So it's a bad disease. You have very few CRs, less than 20%, and a median OS of 12 to 18 months. Although the phase 3 data is not there, but there was a very interesting paper in ASH where they did a retrospective analysis of patients. Even the Waylay trial had patients with high risk MDS. So what they looked at is high risk MDS patients who had first line, where venetoclax was used in the first line together with an HMA, or venetoclax was used. Patients were already taking HMA, venetoclax was added, or patients who had failed HMA. So this publication from ASH, this is what it tells you. It tells you that the HMA, you can see the response rate. Those who were HMA naive, response rates were good, exposed again in the range of 60% and 44% in the HMA failure. And you can see the CRs, the complete remission, the dark blue and the blue bars. Definitely it is there are good number of CRs or hematological remissions when the combination was used. So what happened is, you can see the PFS was definitely improved from your 12 to 15 months. It went up to 20 months. The PFS was definitely improved. Overall survival actually was 20 months and beyond, which I'll tell you what happened to that. It did not significantly improve in this retrospective analysis. Even in the bad subsets, the topmost right part of your graph, you can see the PFS from less than 5 months had improved to beyond 10 months. So venetoclax did add to your HMA as far as progression-free survival was given. But this was a retrospective analysis, and there were very few patients. And the aim possibly of this retrospective analysis was to ultimately your the fitter lot out of it, which was MRD negative, or your patients who went into CR were transplanted, and the transplanted guys did beautifully well. So you can see the red line. It's basically a straight line compared to the others. And what had happened is that their 2-year overall survival, as I'll show you here, again, you can see the overall response rate was doubled. The CR rates were tripled when was added to your HMA. Even if you go to, look at the entire chart, your ASXL1 mutated, your TP53. So all your bad guys also did well. So the PFS definitely worked well. The drug did work well, but somehow the OS did not follow, did not come. It was not statistically significant. There was some small minuscule advantage, but the OS was not there. But the patients were very few. So this was your 35 patients entire out of the entire lot. So you cannot comment on that. Ultimately, the overall cohort, which was the aim of the trial, that the 2-year OS in the transplanted group was excellent, beyond 90%. So what has happened is, as AML, you saw the data with venetoclax was very exciting. What happened is, this is a trial which is possibly ongoing. No results have been available, but this is your high risk MDS, your intermediate high risk and very high risk MDSs, which were subjected to your HMA plus venetoclax compared to your HMA alone. And the data for this will come. So even I'm very sure in high risk MDSs already there is enough literature available that you could be using an HMA alone. You could be using an HMA with the venetoclax. You could possibly be using a triplet, as in the case of elderly AML. I didn't forgot to put that slide because there are trials to HMA plus venetoclax plus an IDH inhibitor, or a venetoclax with an HMA with a FLT3 inhibitor. So possibly you could be using depending on your what your molecular profiling tells you, all the 3 triplets. And if the patient is MRD negativity, obviously if the patient is fit, you subject him to a transplant. If he is MRD positive, you could continue the treatment or use a transplant. So interesting times even in MDS. What about lymphoma, the last part of it? So we all know, as I initially told you, double hit lymphomas, triple hit lymphomas have expression of BCL2, BCL6, and they have been attributed to poor responses or poor overall survival. The standard of care, you could say ARDA, EPOCH, you could say RCHOP, but what this alliance trial attempted was improving on the survival by adding venetoclax, because it, as I told you, you remember the first diagram I showed you, the bullseye effect and the bystander effect. So venetoclax was a bystander. It was one of the BCL2 was a bystander. It was one of the pathways involved, but possibly there are many pathways involved. So what this trial attempted is using a venetoclax with your ARDA EPOCH. What I wonder about this trial is how they came up with a 600 milligram dose and how they decided to use it the way they decided. Because this trial, the only reason this trial failed was, as you can see from the last part of the last slide, the green, I have highlighted it. It was a very small trial. First of all, hardly any 65 patients. But what you should remember is the grade 5, or basically death mortality in less than 30 days, in the possibly early mortality. Just as you say early mortality in transplant. So your conventional ARDA EPOCH, it was 3% compared to 17%. So one patient in the ARDA EPOCH arm died, possibly 6 more died in the venetoclax arm, and it was only and only because of the toxicity profile of this drug. You can, if you go through the full text of the article and the slide, the toxicities were more, obviously, as you expect for an venetoclax plus an ARDA EPOCH. So I wonder why they used 600 milligram rather than using a smaller dose for this study, because already ARDA EPOCH is not easy, and they used it. So in first cycle, they used it from day 4 to 8. Next cycle, they put it on day 1 to 5. Why did they use it initially in the later days and then in the earlier days? It's difficult to say. What was the thought process? If you go see this diagram, the right side will tell you the response rates and the CRs with the venetoclax arm was far better than your traditional only ARDA EPOCH. But ultimately, this is the analysis that came up. So the red line is your ARDA EPOCH. The green one is the ARDA EPOCH plus ven. So the trial failed. So there was no overall survival advantage, and this was only because of the toxicity profile. That is what they concluded. And now there is a trial going on with RCHOP with venetoclax. This is the other alliance study. It's a phase 2 study. Already the accrual has concluded. Maybe you will get data for it. Important thing is, one of the problems with this drug would be how do you use it, where do you use it, and what dose. So it's not an easy drug to use. So that is where possibly this alliance trial with ARDA EPOCH failed, because in my mind, I find no reason why it should have not worked in your double hit lymphomas, which are the bad subsets where BCL2 is present. So the CR rates were definitely improved, but CR does not always translate into an overall survival. So because we used a toxic regime, which is the standard of care, possibly that might have led to the failure. What about your myeloma? Again, the same thing happened. So this is the Bellini trial, where in relapse refractory myeloma, you use venetoclax together with a body Dexona. Obviously, they had to be PI sensitive, proteasome sensitive. The overall survival did not improve. So if you see, this was the trial. Your one arm had venetoclax, the other arm had just body Dexona with a venetoclax. The body Dexona was the standard of care, and venetoclax was added. In this case, it was 800 milligrams. So what happened is, you can see the PFS is better. The HR is 0.58. So 40% of the patients did better as far as PFS goes. It is median PFS is 24 months compared to 11 months for your non-venetoclax arm. But the OS did not improve, and purely because of the toxicity. But what they did is, as I told you initially, very important is they pulled a rabbit out of the hat, that 11-14 guys, you can see the PFS is, the median PFS is 36 months and beyond compared to 9 months. And there was a trend towards overall survival in these 11-14 guys. So HR is, although it has not been reached, but the HR is 0.61. So suggesting that there was a trend towards overall survival also. Looking at patients with high BCL2 expression in myeloma, this is the subset analysis for high BCL2 expression. You can see the median PFS from the left side. It is 30 compared to 9 months. And again, OS, there is a trend towards improvement. The HR is 0.7. So there is definitely advantage in the overall survival as well. They did a combined analysis of this different subset of patients. So this was an investigator assessed PFS of your 11-14 guys or BCL2 high guys with standard risk cytogenetic. So you can see the PFS is 35 months compared to 9 months. And your high risk cytogenetic guys, again, the PFS is far better. It was your high risk guys generally do very poorly on your traditional treatment. So it was 22 months compared to 9 months. So what, again, we come to the same article from Blood, which has suggested biomarker driven treatment for venetoclax. So what happened is, your high BCL2 guys and your translocation 11-14 guys, relapse refractory myelomas, you can see they are doing very well. The VGPRs and the PFS was better. Although it has suggested that there is no OS advantage, but there is definitely a trend towards overall survival advantage as well, indicating that this is a subset of patients where you could be using a venetoclax combination regime in multiple myeloma, and this could be done even in your upfront cases. So if this is the case in the relapse setting, why not in the upfront guys? You already can determine that there is a subset of patients where venetoclax would do far better than your just body lent Dexona. So that would be the future, how trials are there already designed or would be designed by combining venetoclax in the biomarker driven fashion. So what they concluded in this trial, if you don't go through the entire slide, what they concluded is, although the overall trial was negative, but these two subsets, your 11-14 and high BCL2 expression or your poor cytogenetic risk guys, were doing far better, both in terms of PFS, and there was a trend towards overall survival improvement. So that is where it has been recommended in multiple myeloma. So your 11-14 guys or guys with high BCL2 expression, you could possibly be using venetoclax in that, or a BCL2 inhibitor. So if I have to just summarize my entire lecture as till date, there are about 5-6 points I would like to highlight. One is, the point number one is, it's a very potent drug that we all agree. Venetoclax is a very cytotoxic drug, a very potent drug, and it kills cells very quickly. So you have responses practically in the first cycle. Those who have BCL2 expression in a good amount, like a CLL guy or an AML guy or some sensitive lymphomas, we have seen some beautiful CRs, which has given us the hope of an MRD negativity and treatment-free intervals, or a time-bound treatment for our patients with CLL at least. Third important thing is, you can see that some combinations have done very well, like an ibrutinib venetoclax, but some combinations have failed you, like ARDA, IPOCH with venetoclax. So most combinations have worked, but there are some combinations which have not worked. So some research is needed urgently to find out good combinations or good ways of combining this drug to our traditional chemo, so that we could improve our overall results. Obviously, if you go aggressive, There is always an saying in oncology, and many of our senior colleagues believe that if you give give the entire thing upfront, what do you do later on? So why? Because there is definitely a problem of resistance. So you will develop resistance to BCL2 inhibitors. It could be in the BCL2 itself, or it could be beyond the BCL2. And what it does is to make the venetoclax resistant to your traditional your BCL2 inhibitor. Obviously, you would get resistant. So one of the mechanism of resistance is in your BCL2 protein. The most common one is G10V, 101V. Obviously, I told you first slide, remember MCL1, BCLXL. So MCL1 overexpression, or it basically just like mTOR is an escape mechanism for most cancer cells. Similarly, MCL1 works as an escape mechanism for BCL2 inhibition. So MCL1 expression is the second most common way where resistance develops to venetoclax. In AML, it would be a FLT3 ITD or a RAS-MEK pathway where it works as a bypass to your BCL2 inhibition and leads to resistance. So there are several ways. This is another beautiful article which tells you resistance to venetoclax therapy, the mechanisms, how this resistance happens, and how do you circumvent it. So there is already, as I told you, MCL1 inhibitors are being developed. They are there. Combining MCL1 inhibitors with venetoclax, although it would be very toxic, but then there is already work being done as to how this resistance could be circumvented. What about, as I told you, the best part of the articles I read through was the biomarker driven treatment with venetoclax. So that is where the research lies. As in the case of myeloma, when there is a very potent and a toxic drug, the best way of treating it is you hit the bullseye, or you find the precise group of patients where this drug would do so well that you would have to use it, rather than using it right, left, and causing a lot of financial and both medical toxicities. And obviously, combination of regimes have to be identified where this drug would work better than others. Last couple of slides, I thought these are slides I should put in the last, because these are slides possibly have to put it in our clinics, because when you're using a venetoclax, you should know this. Otherwise, it's like flirting with danger. What do you do about the side effects? These are the common ones. It tells you what to do. If you have a myelosuppression, grade 3 and beyond, you stop, you use GCSF antibiotics, and you might restart with a lower dose. If you have infections, you treat them, start with a lower dose. You obviously, TLS is a very important part of the management of venetoclax. And as far as TLS goes, I'll tell you how to manage TLS. Another very important part of venetoclax treatment is drug interactions. I didn't tell you this first, because if you are using venetoclax, you need to remember this. Just put this chart in the file. So if you are using fluconazole, these are CYP3A4 inhibitors. So if they are moderately sensitive, like a moderate inhibitors like a fluconazole or an aprepitant, which we commonly use in chemo, or a dilzam, ciprofloxacin, so you reduce the dose by 50%. Otherwise, the patient could have fatal toxicities. Where you need to remember the most is your strong CYP3A inhibitors, which is voriconazole and posaconazole, because we use a lot of these drugs in our hematolymphoid malignancies when there are infections and some EML in profile excess. So you reduce the dose by 75%. Otherwise, the patient could have fatal venetoclax toxicities. And I have known my colleagues using posaconazole, because you have generic posaconazole available, to reduce the drug, the doses of venetoclax, because venetoclax is not available, and what is available is very costly. So as Indians, we call jugaad. We have always found a jugaad for everything. So some people use posaconazole together with venetoclax just to reduce the dose from 400 to 100 milligram. So the cost of the treatment increases. Whether that is advisable, should be done, I don't know. But I have found people doing that. What about CYP4 inducers? The most common is the anti-epileptic drugs like carbamazepine, phenobarbital, your HIV drugs. And in this case, what they do is they reduce the availability of venetoclax. So possibly the requirement of drugs is so high, you should look for alternative drugs instead of that, because there is no point in increasing the doses of venetoclax. So this is one part which we should all remember in addition to side effect. And the last part and the most important part is this. And if you go through this slide, you just put it in your patient's file. It makes life very simple. So what it says is assess, prepare, initiate. You remember API. So what is assess? Every patient you are thinking of putting on venetoclax is look for the tumor burden. So there are three categories. One is low tumor burden. You have lymph nodes, most of them, all of them are less than 5 centimeters, and you have an absolute lymphocyte count of less than 25,000. So what is medium tumor burden? You have a lymph node which is more than 5 and less than 10, and you have an absolute, or you have an absolute lymphocyte count which is high, beyond 25,000. And the high tumor burden guy is you have huge lymph nodes more than 10 centimeters, or you have a very high ALC. So what do? The first step is you assess the patient. Second step is you prepare, and prepare means 2 days earlier to starting your first dose of venetoclax. In your low tumor burden guys, obviously you could just go do away with a oral hydration of 1.5 to 2 liters together with an allopurinol. And in the medium tumor burden guys, you obviously do the oral hydration together of allopurinol, but you could consider using IV hydration as well in outpatient basis. What about high tumor burden guys? So high tumor burden guys, you have to use IV hydration 150 to 200 ml per hour in addition to the oral hydration. Obviously, you would use the allopurinol, and you should be using a raspbericase if the uric acid is more than 8. And the last but not the least important part of it is initiate. Assess, prepare, initiate. What is initiate is your monitoring. Obviously, when you are using venetoclax, this is the hardest part of it. You need to keep monitoring your patients. And the chart is telling you before the dose of venetoclax and after the dose of venetoclax. So if you have a low and a medium tumor burden patient, you do 3 values: pre-dose, 8 hours post-dose, and 24-hour post-dose. You do your biochemistries, your create, uric acid, phosphorus, your potassium, you do that. And every ramp up that you are doing, you have to monitor it. Later on, the next ramp ups, maybe you cool down. In your high TLS guys, it has to be even stricter. You can see your every ramp up, you can see you do it pre-dose, you do it at 4 hours, 8 hours, 12 hours, 24 hours. So you keep doing it in every ramp up. Once the patient has tolerated well, maybe you can reduce the from 6 times a day to 3 times a day. But this is a very important part of monitoring TLS, and this is what the protocol says. And you'll easily get this from the original website of Venclexta. So again, these 3 slides possibly have to be put into the file of every patient where Venclexta or venetoclax is used, because it is that kind of drug. When it is so good, it always has to be dangerous. So you have to be very careful. And before I thank you, as I told you, this is the 2 articles which I found that were most interesting. Most important among them is this article, as I told you, because it tells you about how you judiciously use venetoclax or biomarker driven approach. There were several other articles, and this is the publication from ASH. This is the Ham-Wasserman lecture. As you all know, it probably is the presidential lecture at ASH, where I think last year or before that, BCL2 was the theme, and the entire subject was presented there: BCL2 inhibitors, their development, their uses, and their future. So these were sources from where I made most of my presentation. And with that, I like to thank all of you and Dr. Agarwal for this opportunity.
Thank you, Abhishek. Wonderful. Marathon job, a lot of hard work, obvious for everybody to witness. And I think we are all wiser. So give you a rest for 5 minutes and come back to you with question and answer session. And during these 5 minutes, we will answer the quiz that was put to everybody. So the quiz that was put today was regarding this 70-year-old man who has fatigue and bony pains for 3 months with the osteonecrosis of 2 bones. And bone marrow showed that there is a diagnosis. The disease is a genetic disease inherited in autosomal recessive fashion. And these are the characteristics of this disease, not necessarily in this patient, but overall, it causes anemia, thrombocytopenia, splenomegaly, platelet dysfunction, coagulopathies, gammopathies, myeloma, and other hematological malignancies. Well, that is the marrow, and that is the cell that was there to make a diagnosis. You've got this large cell, eccentric nucleus, and a characteristic cytoplasm, and there are a bunch of these cells all over there. You can see a closer look of it: eccentric nucleus, large cell, and you can see the characteristic cytoplasm. And this cytoplasm is PAS positive. You can see 1, 2, 3 cells. And not belonging to this patient, but this is a good picture of a splenic biopsy. And you can see those cells filling the whole spleen. It's all over the nucleus and the same type of cytoplasm, large cells. This is Gaucher disease rather. And what you see in the cytoplasm is the characteristic crumpled paper appearance, eccentric nucleus, large macrophage histiocyte, which is containing this kind of crumpled cytoplasm. So Gaucher disease is an autosomal recessive disease. It's the commonest of the LSD, that is liposomal storage disorder. There is a genetic deficiency of lysosomal enzyme, glucocerebrosidase. Gaucher disease, GD, is named so after the French physician Philippe Gaucher, who described the first case way back in 1882. From 1882 to 1965, it was in 1965 when the deficiency of the enzyme was first found. This disease is relatively a rare disease, though the commonest of the lysosomal storage disease, but its frequency in Ashkenazi Jews is extremely high. It is 1 in 850. There are 3 types, and as hematologists, we are concerned with only one type, that is type 1. Type 2 is a fatal disease in the first 2 years with CNS involvement, and type 3 is a lesser degree but neurological manifestations. So type 1 is the non-neuropathic type, and that's what comes to a hematologist. And 95% of the patients in the world are type 1. And these patients can be so benign that they can present for the first time, even in the 7th and 8th decade of life, without having gone to a medical person anytime for a Gaucher-related symptom. And that's what our patient was as well. The common hematological manifestations are anemia and thrombocytopenia, which are not only because of hypersplenism, but also because of the marrow infiltration by these cells, and also because it's an inflammatory disease with a lot of cytokines producing anemia of systemic disease. So it's multifactorial. The spleen is invariably enlarged. It's quite large, it can be massive. And then there are bone lesions when the cells in the marrow sort of erode through the bone, create a lot of osteoporosis and even pathological fractures. And the bleeding can occur beyond thrombocytopenia. And this is because of hepatic dysfunction and a lot of platelet dysfunction and loss of number of coagulation proteins. So hemostatic abnormalities have been described beyond thrombocytopenia as platelet dysfunction, factor deficiency, even von Willebrand disease, etc. And this is very important for a woman who is undergoing pregnancy, delivery, cesarean, or anybody who is undergoing a surgery. As I said, this is an inflammatory disease, as a result of which there is hyperferritinemia, and a constant stimulation of B cell leads to polyclonal and subsequently monoclonal gammopathy, mimicking MGUS. And there can be other immune abnormalities. This can lead to plasma cell malignancies, overt multiple myeloma. In the beginning, it was thought that the connection between Gaucher and multiple myeloma was fortuitous, but it wasn't. There's a distinct increased incidence of myeloma in Gaucher disease and other B cell malignancies as well, many types of low-grade lymphomas. The target cell is a blood cell, that's the monocyte macrophage, which in its ancestor is the myeloid progenitor cell. And glucocerebrosidase accumulates in the macrophages, and the maximum amount of macrophages are in the spleen, liver, and marrow. So that's the target organ. And because of the inflammatory state, there is secretion of cytokines, which leads to polyclonal, finally monoclonal B cell proliferation. Any disease which is rapidly proliferative, there can be pseudo Gaucher cells in the bone marrow. So you have a patient of thalassemia, you have a patient of chronic myeloid leukemia, they all can have Gaucher-like cells in the bone marrow. So you have to be very careful. The morphology of the cell is not adequate to make a diagnosis of Gaucher disease. So how do you make a diagnosis? Diagnosis is made by documenting deficiency of the enzyme in the leukocytes, the deficiency of acid glucocerebrosidase. Or you can do the genetic studies by looking at the mutation in the GBA1 gene. And that's the treatment. When I was a student or resident in 1970s, we would do splenectomy. But that would be just a palliation because it will lead to hepatomegaly, it will lead to more bone disease, more fractures, and a morbid life. Then came bone marrow transplantation. Bone marrow transplantation took care of hematological problem like anemia or thrombocytopenia, but was obviously not a cure. And the real two treatments, which are not cure, but are the real treatment, is one is enzyme is missing, so you replace the enzyme. So this came quite some time ago, 20, 30 years ago, IV enzyme replacement, what is called ERT. And this is intravenous, given OPD once every 2 weeks. And lastly, about 20 years ago, exactly in 2003, came what is called SRT, that is substrate reduction therapy. You try to reduce the substrate. So then you don't even need the enzyme. And this is done orally every day. SRT is an oral medication which decreases the production of the glucocerebrosidase that the body is making. And fortunately, because this is a rare lifelong disease, manufacturer of both these therapies have patient assistance program in huge way. So if you have a patient of Gaucher, don't leave that patient alone or do splenectomy or bone marrow transplantation. Opt for these two treatments, which are very productive and which is cost-effective way because the companies help you. A patient means a lot to them because it's a rare disease, and one patient means lifelong treatment. So the answer that was expected was Gaucher disease, and if you were smart, it would have been Gaucher disease type 1. We didn't get the answer Gaucher disease type 1. That does not matter. There were 7 correct answers, and the 2nd to 7th were between 11:43 to 12:53 a.m. 12:53 p.m. rather, 11:43 a.m. to 12:53 p.m. And these were in this order: Dr. Sumit Mir, Dr. Christopher Liam, Dr. Mohammad Mir Hussain, Dr. Babita Sodhi, Dr. Ramesh B, and Dr. Kajal Shah. So congratulations for answering correctly. Many have answered many other answers, but you 6 were the correct ones. And then we come to the fastest finger fast, and that is Dr. Yoga Lakshmi. Dr. Yoga Lakshmi has been regular winner of various quiz contests so far in last 2 years. And as you all know, she is senior resident DNB hematologist at Gangaram Hospital, New Delhi. And she's a discussant today as well. So congratulations, Dr. Yoga Lakshmi. And that's it. And we go to the discussion now. So those of you who want to ask questions, you can open your videos, put the question, hand raise sign. We start with Abhishek Dudatra. So Abhishek to Abhishek, go ahead.
Yes. Excellent talk, Abhishek sir. So as you correctly mentioned in your talk that AML is the area where we are using the venetoclax maximum now. And I think everyone's experience is that results are very good with manageable toxicities. So so now what has happened that whenever we are counseling patient for 7-3, on back of the mind, there is always a thought that why not to give AZA venetoclax to all the patients irrespective of fitness. So what are your thoughts on that, and where have you placed this AZA plus venetoclax in your routine practice?
So thank you, Abhishek. As of today, I think elderly AML, I would always go by the indications which are there in the prescribed drug. But obviously, as you said, it is not just you. There are people around the world who are looking at adding venetoclax to whatever the combinations are there, which we already use just to improve the CR rates. And ultimately, you guys are there to transplant them. So it is work in progress. It will come up. Point is, as I told in my conclusion, it is not an easy drug to use. So you'll have to find ways. Some smart person has to find ways as to how to use it without killing the patients.
Right. So is there any like comparison between mortality we see in 7+3 versus AZA venetoclax?
In the elderly?
Yes.
Elderly, definitely it scores better than your conventional 7-3.
Right, but that's for unfit patients, right? But
yes, unfit patients. So fit patients, I'm not aware. Fit patients, whether there is a comparison between both of them, 7-3 with the AZA venetoclax upfront. I'm not aware. Maybe sir is aware of some data.
No, I mean, Abhishek, one thing that has been accepted worldwide is that 7+3 can be curative.
Right.
When-based protocols are not curative.
Right.
They should not be taken as a replacement for a person who is fit for 7+3 is likely to be curative. And even from that angle, those who have got NPM1 mutation and IDH mutation, where the results of Ven are fantastic, even in that category, if they are fit for 7+3, fit for transplant, and that will remain as the standard of care. And you will keep the rest for the unfit patients only.
Right.
As of today, everything can change in a couple of years.
Sure. Thank you, sir.
So Uday, your question.
Thank you, sir. Thanks for the opportunity, first of all, for calling us for this educative session. Excellent lecture, Dr. Abhishek. I basically wanted to ask all the panelists about how many of us are actually using venetoclax in combination with azacitidine for either AML or when we are doing venetoclax with CLL, because our experience hasn't been really great. We have given for around 14 or 15 patients. For around 7 to 8 patients, we couldn't give the full doses because they develop severe cytopenias. And in the residual of those, another 7-8 cases where we gave venetoclax in the prescribed doses, the patients ended up with such severe cytopenias that they did not recover at all. And the mortality had been actually like higher than what we routinely see. But anyway, that could have been one of the situation, or maybe our patient selection was not good. But definitely, both from Agarwal sir and from the other panelists about their personal experiences of using this in AML and in CLL.
First, Abhishek.
Sir, as I did my lecture also, very few in CLL, practically nil. In AML, yes, and you rightly said most of my patients have never reached 400. But then I think that has not been the case that we had to put them on 400 and the patients had severe problems. So the basic elderly unfit guys with AZA and decitabine, so you use a dose which they can tolerate. You generally tend to tailor and put them on that treatment, and they did well. Rightly said that 400 is a difficult task, challenging. A lot of problems do happen, but then manageable. I didn't have any problems in some of the few patients which I have used. Maybe Dr. Agarwal can add.
So we have plenty of patients now on venetoclax, but forget 400. We have never given 400 to anybody. And the method which Abhishek described, posaconazole with venetoclax, is the way to go. And why not? You got the generic posaconazole, and those who can't afford posaconazole, you got generic voriconazole. And you give venetoclax maximum 200, and half the patients 100 mg per day, and maximum 14 days, and half the patients 7 days. So when you follow these two regimens, 7 days to 14 days, 100 to 200 mg, and everybody with voriconazole or posaconazole, I think you can prevent morbidity and mortality of venetoclax. It's a great drug because, I mean, what were you doing otherwise? Only azacitidine or cytosine albinocyte. And now you've got this combination. And as Abhishek said rightly, in India, though worldwide it is not approved and they can't do it, but we do it for MDS. AML it is approved, MDS it is not approved, but we do for both. And in CLL, this is the best option now for second line. Once you have used BTK, then what are you left with in most of the patients? If you don't want to use chemotherapy. Cost is an issue because at the moment you have cost running into lakhs. But with this kind of methodology, 7 days, 14 days, 100, 200 mg, it becomes reasonably in cost for a lot of patients, and you don't have the expenditure on the support therapy also.
Thank you, sir.
Anybody else wants to answer? Because I'm sure.
Yes. Yes, sir. Can I go?
Yes.
Okay. Yeah. So just like you said, sir, whenever we are treating a patient of AML who is unfit for intensive therapy, I would say we should not treat that particular case as a medical emergency. We tend to give all AML patients who are suffering from infection, who have severe cytopenia, we continue on venetoclax. Thinking that if we stop it, if we disrupt the treatment, he may have less than optimal outcome. But by that way, we are pushing them into more severe neutropenia and infections. So like a patient who is on palliative therapy, who is not on intensive therapy, even if the goal of treatment is complete control, we should be slow in treating those patients. And like you said, in combination with azole, we can decrease the dose, but then we should be more promptly, we should stop the therapy whenever the patient experiences a problem. So if a patient survives, then only the drug will take, it can give action. So that is what I thought. And the second, one more question is, like you said, sir, is do you have access to any data, particularly from Mayo? So I think there we've been using azacitidine plus venetoclax, where they give azacitidine for 7 days, like the standard protocol, but then they are using a venetoclax for 7 days only, not 20 days continuous therapy. So
max 14 days, max 14.
Right.
Okay, Ghanshyam, your question.
Yeah, good afternoon, sir, and good afternoon, friends. So that was really a heroic task by Abhishek. So you have done a great job. So I have a comment and a question. So being a medical oncologist, but if you see the BCL2 expression is almost seen in 100% of malignant melanomas. So any thoughts of, because we don't have a really for immunotherapy, and those BRAF inhibitors are far away from our patients, and we know their, so what, any thoughts beyond lymphoma, leukemias and myeloma? And second is that, so as I rightly said, so since these are the drugs where lots of cytopenia, so it is a good idea that we can have a voriconazole or a posaconazole as a prophylaxis and also a dose reduction. And the third question is that, do you see tumor lysis frequently in also a relapse setting, or it is only a treatment-naive patients?
So to answer the first question, I told you in the middle part of that graph, there are so many malignancies. So today we were looking at only hematolymphoid, but I think there is always an opportunity of using such drugs in palliative settings, even in oncology, because as you rightly said, BCL2 expression is there. Whether it is the only expression, as in the case of a high-grade lymphoma, it failed. Whether it is the only pathway working and whether only venetoclax could work or combination used, that is a matter of research. So, but then it is a food for thought, and I think this drug has been tried in other. I didn't go through every indication. There are people who have tried it in everything and anything, but it has not worked. So that is food for thought. Then the second part of your question, that obviously a common way of practicing that we generally tend to do as private practitioner is use starting a lower dose and possibly building it up to a dose which the patient can tolerate. I don't think we follow the book that you have to give hellbent, as Ankit said, 400 milligram, whatever be the case. So patients, you manage your patients. Each person has an individual way of managing his own patients, but patients do tend to tolerate. There has been problems with the drug, neutropenia, infections, tumor lysis. Obviously, new cases, yes, you are right. New cases, I see more tumor lysis than in relapse guys, because by that time you are in control of the disease, early in control of the disease. So in new cases, you tend to have relapses. But as I had shown the last 3 slides, you will have to put it in every file. That is the trend which you need to follow, because these guys do have this drug does have its problems in the form of cytopenia. Many times we had to use GCSF as well. So many of us are very reluctant in using a GCSF in leukemias, but there have been patients with severe neutropenia where GCSF would have to be used unless and until you don't have any other option. So I think those were the 3 questions you had.
Yes, thank you so much.
And tumor lysis is a problem in CLL.
Yeah.
Not that much of a problem for the other. CLL, 3 months you should give the BTK. Then only add venetoclax, and that also in the fashion, which is extremely slow. In AML, Abhishek said rightly, 100, 200, 400, you can keep jumping within 3-4 days. Here you go in weeks, not in days in CLL. So that is what gave it a bad name, because in the beginning, no one knew all this. So now it's manageable. Dr. Jatin.
Thank you, Agarwal sir, once again. And I want to really congratulate Abhishek for doing such a wonderful job. It was really amazing, really amazing. Being a medical oncologist, I have used this product very sparingly, and yes, we dread the toxicities of this product, and actually, it's a learning curve. I have a very practical question which I faced in my practice, that sometimes, in many empanel patients or otherwise also, people are not able to afford this medicine upfront. Suppose we have started with the azacitidine or decitabine in an AML patient, and they have responded by at least a hematological remission has been achieved. So in those cases, suppose the patient says that, yeah, now yes, I can afford venetoclax, or they are able to procure venetoclax. When should we use the venetoclax? Is it when the hematological remission goes away, or you can add on later on? Any experiences?
So if you are thinking about AML MDS, I had shown you data that you could use it in an upfront case. You could use it in a patient there was data to suggest that even if patients were an HMA, you could add it. So the trial took patients which were already there on HMA for 4 months or 4 cycles, and venetoclax was added, and the responses were definitely better. So to answer about AML, definitely you could add the drug later on as well, upfront as well, if the patient is affording. CLL, as Dr. Agarwal rightly told you already, it is 3 cycles and then you start venetoclax. So that gives you a window of using it. If the patient has already lost remission, then he is a relapse candidate, then he is definitely a candidate for venetoclax. So then the treatment would have to be changed. If you are an ibrutinib and patient has failed, possibly he is a candidate for a CD20 with a venetoclax. So second line treatment would have to be used. And in the third line, a PI3K. So in AML, I think you could use it. In CLL, if the remission has gone, you would have to use it. That is where the indication is.
Thank you.
Yeah.
And only one thing Abhishek must have mentioned, and I might have missed it also. I couldn't listen to the whole talk because of certain more things. In deletion 17p and TP53 mutated CLL, because venetoclax is a time-bound treatment, it is not the preferred treatment. Because those are conditions where you want to give indefinite treatment, and therefore this is not the preferred. That's the only CLL where this drug should not be used by preference. So that was one additional thing. Dr. Stalin.
Yeah, thank you, sir. Thank you for the opportunity and a very nice talk, Abhishek, sir. The first part of my question was actually answered, that what is the dose you routinely use in your clinical practice? That is with azoles, the 200 mg is fine for using it. So a practical thing is approximately 30% of cases in my setting of AML present with sepsis. So where some sort of infection. So where we can't deliver the 3+7 chemotherapy. So even if the patient is young, so what is your experience of using azaven in those settings? And when we have used azaven for 2 to 3 cycles and the patient achieved CR, then can we stop it and consolidate with HIDAC in them?
So I think patient is in sepsis. I am telling you from my experience, I would not go for an azaven. I would probably go on an aza, try to improve the patient as far as the sepsis goes. And obviously, after 3-4 cycles, if the patient has improved, you add a ven. That is the way to do it. Adding ven in a septic patient would be a dangerous thing to do. And what was the other part you asked?
So if we have used an AZA or azaven in the patient with those infection and the patient attained a CR after 2 to 3 months, will you consolidate? If it's a good risk or an intermediate, will you consolidate with HIDAC or continue azaven till progression?
So if the patient is gone into a CR or a remission, is a candidate for transplant, I think the transplant would be the treatment of choice. And if he's not a candidate for transplant, then consolidation would be the standard of care. So once the patient is in CR, a young chap, definitely he has to go to some form of definitive treatment. He cannot just continue an azaven. If he's a 70-year-old chap where there is no options left, I would continue an azaven.
So what is your current experience of using that low dose of venetoclax with posaconazole or voriconazole?
So I haven't done that, but I've seen my colleagues doing it. I would better do a lower dose.
Stelline, it is excellent, and it is all in the literature. It's not only for India type of countries. Dr. V from Australia has published in Blood the detailed 3-page write-up on how to use venetoclax together with antifungal agents. That whole thing is on voriconazole. It's not on posaconazole, but fair enough. And he has given 2 webinars in which he said they in Australia do not use 400. They use 100 to 200 plus voriconazole.
Yeah, we currently practicing the same, sir. We are using either 100 to 200 with voriconazole.
India, we are forced to do also.
Yes, sir. Yes. Thank you. Thank you.
Where is the money? Okay, Aishwarya, your question.
Good afternoon, sir. So thank you for the wonderful talk. It did justice to the talk. Today's title of webinar covering A to Z of the drug. Basically, I just wanted to know what are the difference, why we prefer aza-ven compared to desitabine and venetoclax. What are the differences?
So I skipped that part of the slide. It did not do as well as an aza-ven. So to answer it short, maybe Dr. Agarwal can add.
No, I would say in everybody's experience, desitabine is a little more myelotoxic agent. So when you are going to use 2 drugs and venetoclax is so potent, you will have to be a little careful. I have never used desi with venetoclax.
I have seen this desitabine and venetoclax combination. So like when given an option, we should always prefer for the aza-ven coming because of the toxicity part.
I think even in the trial, the improvement was with aza-ven.
Any of your...
The only 2 places where it worked was aza-ven and low-dose Ara-C-ven. So desitabine, as sir said, probably even in lymphoma, some regimes proved to be toxic, and that is where the advantage was lost. That does not mean it doesn't work. Probably there has to be some readjustment in the dosages, as we are all discussing, using posaconazole to readjust the dose. Possibly there is where the key lies. Somebody has to figure out how these regimes have to be tailored.
And would you share any of your experiences in upfront CLL with venetoclax as monotherapy?
So I have been not so lucky. Maybe Dr. Agarwal can add.
No, but monotherapy with venetoclax is not recommended at all. You have to do it in a standard way with a anti-CD20 antibody. And the one which was researched was obinutuzumab. I see a question in the question box whether obinutuzumab is available in India from Dr. Tejaswini. Yes, Roche is waiting for the clients. So they will be delighted if you use obinutuzumab. Most of the people use rituximab because there's a huge cost difference. But Roche will help you as much as possible if you take up a patient on that. So that's the combination, venetoclax with this. And Dr. Abhishek presented the data on total oral therapy, where you are giving a BTK inhibitor with BCL2 inhibitor. And I think in future that may be the way to go. People are not very confident because that data is inadequate data, but that could be the way to go even upfront when a patient prefers total oral therapy. But we are not sure about the long-term outcome, and the MRD data that matches the one of venetoclax with the CD20 antibody. Venetoclax alone, no. Only BTK inhibitors alone, yes. In fact, ibrutinib with rituximab is just as good as ibrutinib alone. You don't have to add over there. Okay, Ashok, Dr. Ashok.
Good afternoon to all. Thank you, MB sir, for the opportunity. It was really a feast and really a to Z of a topic. My question is for highly susceptible disease, example CLL with BCL2 inhibitor. So what is the optimal duration of treatment? Is it fixed or then can be adapted as per the depth of MRD clearance?
So as of today, I think if you go by the trial data, you will have to use 12 cycles. Using it beyond that, then you'll have to do MRD. So as Dr. Agarwal already said, that data is phase 2. There is a trial for phase 3 as well, but that data is not the standard recommendation now, because the problem is how do you do an MRD? How do you monitor the MRD? When do you restart? Those are questions need to be resolved. So you could be using an IR, ibrutinib with the venetoclax in your patient, but if you are using ibrutinib venetoclax, then you'll have to follow the trial data, which suggested at least a minimum of 12 cycles. and then doing an MRD and tailoring your treatment accordingly. So if you are using venetoclax-based regime, and obviously first line you had obinutuzumab with the venetoclax again, that was a fixed duration trial. Venetoclax was used for 12 cycles. Even in the relapse setting, your ven rituximab, it was a fixed duration trial where ven was used for 24 cycles. So there are, in the approved cases with anti-CD20, there are fixed recommendations where you use for 12 months, 24 months. And in IR, that is the only, what do you say, still unsolved puzzle. It works wonderfully well, but where do you stop? How do you stop? And how do you monitor in a country like India?
Thank you. Thank you very much.
Thank you. Dr. Yoga Lakshmi. First of all, congratulations for winning the quiz. And now you can go ahead.
Thank you, sir. Thank you for the opportunity. And Dr. Abhishek, sir, it was very comprehensive, especially for us postgraduates. Sir, I have a question. Given the high rates of translocation 1114 in amyloidosis, what is the role of venetoclax in the treatment of amyloidosis?
So I'm sorry, I didn't go through that data, but other indications which I am lost for is Waldenstrom's. There is where venetoclax is there. In amyloidosis, I don't think there is approval for venetoclax as of today. Correct me if I'm wrong.
Yes, sir, it's not approved.
Yeah.
But do you have any experience of using it in amyloidosis?
I even didn't find it in most of whatever I read about venetoclax. So maybe there is some data around, but nothing to be talked about. Maybe
Okay.
sir can add.
I mean, Cyborg-D with or without Darzalex has given such fascinating results in amyloidosis that despite, as you rightly said, very high incidence of the genetic abnormality where you're expecting venetoclax to work, it is still kept as a second-line treatment. Amyloidosis is not myeloma. So patients get into remission, then you don't need any maintenance. They can remain into remission for quite some time. So at the moment, Cyborg-D plus minus, if you can afford, Darzalex has become sort of standard of care for everybody. And once you complete that course, you may give Darzalex maintenance, you don't give Darzalex maintenance. Now, venetoclax has to be shown, as Abhishek presented so many conditions, that just because you have the molecular abnormality, the drug will be superior. You take myeloma, even if you do the FISH study and show that venetoclax, patient is eligible for venetoclax, you will not use venetoclax upfront. Same thing applies over the amyloidosis. You will not use in clinical practice venetoclax-based protocol upfront. So maybe a couple of years more and you may have some replacement.
Can I add, sir, if you permit here?
Yes, of course.
Sir, I think she's an upcoming academician. So recently the data has come up on amyloidosis. So that's why she might have asked this. So what people have seen is the translocation 1114 is very common in AL amyloidosis. So with the corollary of using 1114 myelomas, the benefit of venetoclax. So the Mayo Clinic has just started a trial this year in the month of March of using venetoclax in amyloidosis, in relapse refractory amyloidosis. As MB sir has said, so the first treatment remains to be, as sir has just now enumerated, Cyborg-D with Darzalex plus minus. So, but yes, in relapse refractory amyloidosis or patients with cardiac amyloid, they have done that. So they have shown a pilot study of 12 patients wherein they have shown that it's going to benefit. And now based on that, they are now doing a larger study and they have just launched the study. So as sir said, maybe in a year or two, we'll be able to come to know whether venetoclax can actually change the way we manage amyloidosis. Thanks, sir, for allowing me to give the comment.
Pleasure. Thank you. Okay, we move to Dr. Kajal.
Dr. Abhishek, there is a very good informative lecture. Actually, we are using venetoclax plus bortezomib in relapsed acute lymphoblastic leukemia. In that condition, we found somewhat good response when we are not using other intensive therapy. So did you use in relapsed refractory acute lymphoblastic leukemia?
No, I have no experience with that. Maybe others can put pinch in.
So MD Anderson has put venetoclax in T-cell acute lymphoblastic leukemia protocols.
Yes, sir. Yes, sir. There are some papers are there.
An adjunct to the existing drugs. Yeah, there are papers, sure. But it's an adjunct to the other drugs. At the moment, it has not really become a standard of care. But yes, they've got all this, like Uday mentioned just now, there are protocols going on where venetoclax has been included in the protocol, whether it is mini hyper CVAD or other protocols, it is added for T-cell lymphomas.
Yes, sir. Yes, sir.
T-cell ALL.
Yes, sir. And sir, miss in relapse refractory CLL, we are using venetoclax plus rituximab, and we have to use 200 mg dose because of there is side effect of venetoclax.
Yes, sir. If you use that with voriconazole, you are as such making it 400.
Sir, we are using without voriconazole.
Okay, right. So that is less than the recommended dose.
But sir, with 400 mg and 300 mg, our patient develop neutropenia. So they cannot tolerate venetoclax dose of 400 mg.
Right. I mean, that all has to be taken into account. Yes. Any more question from you, Dr. Kajal?
Thank you, sir.
Okay, Dr. Sanket.
Thank you for the opportunity, and Abhishek bhai, it was an excellent talk about the venetoclax. There are a few comments and a question from my side. So the first is, as sir has mentioned, when we are using it with azoles, we are not actually reducing the dose. We are giving the same dose. It is just we are reducing the cost of the treatment. At the same time, we are providing prophylaxis. So we should not consider it as a reduced dose when we are using with azoles. That is the first thing. The second thing, there is recently, I think MD Anderson has published that.
I didn't get this statement properly.
No, sir, what you are saying is exactly when we are using with voriconazole 200 mg dose, it is actually we are providing 400 mg dosage. So it is not reduced dose voriconazole or venetoclax, it is just the equal dose with reduced cost.
That's right. Perfect. Agreed.
And the second one is recently, I think MD Anderson has published their data, phase 2 data with the AML in the 7+3 with venetoclax. And they have shown superior response rate compared to the their previous cohorts. But however, how we can incorporate that data into the Indian settings when 7+3 is so much toxic upfront, to use venetoclax to that, it is still a question. But my more important question right now is, in CMML, we are using azacitidine now. So can we extrapolate MDS data, which we are using AZA with venetoclax? In CMML also, can we use AZA with venetoclax?
So about your MD Anderson data, there were so many things from ASH 2021 which I could have put. I had put one slide with flag IDA, and that showed excellent responses. I didn't put that 7.3 slide. I could have put that also. So definitely it adds to it. That remains a different question, whether it is a long-term solution. It improves the ultimate goal of the treatment is overall survival, because toxicity and long-term transplantation all would add to the survival to it. So that was a very small, I think 30 patient data for a 2-year follow-up. So definitely there is room for improvement even in the upfront settings, but whether that is the standard of care as of today, I don't think it's so, because you have several competing molecular drugs like IDH inhibitors, your FLT3 inhibitors. So probably your new AML is going that way. That is what I feel. It's going towards more 7.3 with, as sir said, standard 7.3, you add on to your molecular targets and then ultimately achieve remission and do a transplant. So that is where it is going. About CMML, I have no idea. Maybe somebody has done it, he can tell you, but I'll have to read through it then.
Okay, fine. We move. Ankit.
Yes, sir. Thank you. Abhishek bhai, thank you for that wonderful and comprehensive lecture. So I was waiting for somebody else to ask this question. It's $1 million question. Where do we procure the venetoclax? And is there any preference for some particular brand, original molecule versus generic brand? And is there any way we can get the drug approved by DCGI and in legal way so that the patient can get benefits from say insurance? So this question is for Sir Abhishek Bhai and the rest of the panelists.
So I won't answer it because you stay next door to me. I procure it the same way as you procure it. So I don't think that should be answered on an educational platform because
No, but is there
that
any
is not the
preference
legal way of procuring it.
So then, is there a legal way? That is the question. For India,
maybe sir can answer.
Well, I suppose there is no difference. You have got generic from Bangladesh and you got generic from Sri Lanka. The cost of that comes to somewhere around 1.5 lakh per month, as against the Ireland product, which comes to about 3 lakhs plus per month. In practice, 90% of patients we've used is the Bangladesh preparation. And I must say, efficacy-wise, there has been no problem whatsoever. And it is equally toxic. So that shows that it is equally effective. And the suppliers are same in Maharashtra and in Gujarat. I think there are same 5-6 guys who are supplying it.
Listen, I was offered so that a patient can procure by DCGI license from US based on our prescription. Would it be possible? And
anybody can procure any drug for personal use with the DCGI's permission. That happens. Only that's a long procedure. It takes 2 weeks to 3 weeks.
Right.
So guys get you the drugs because they invariably have some stock with them. And so on paper, they show you it is patient to patient. And they complete all the legal formalities, give you the bill, everything they complete, but they keep some stock with them. So they're ready to give you the drug next day.
Right.
That's the advantage of going through these guys. And all paperwork, patient gets fed up of doing the paperwork. You and me don't have time. So they take care of all those hassles. So it's easy for you, it's easy for the patient. And I think the 5-6 guys who are supplying in Maharashtra are quite genuine. And they are all supplying the authentic products.
So recently there was there were some raids and the situation because of the I don't know, custom department, somebody there was a shortage and some of the patient may had to switch to some other brand or a generic brand. So that was there because there is always a concern about this. The same way ibrutinib, 2 of the brands have stopped manufacturing generic brand because of the innovator, the legal process between innovator and the generic brand. So same way for this also, there is always a concern every time patients relatives ask how many months supply should we keep. So, and the last question for CLL, like Abhishek Bhai showed that we start with low dose 20 mg. So is it possible? So how do we do? So
clinically we start with 100 mg because as you just rightly we were discussing, we have that option only with us, the Bangladeshi guy. And to answer your first question, I think you should leave it to the patient to procure these drugs rather than getting into it. So that will make sure that you are, I could understand your concern. You are nowhere involved in what is going on, because obviously that is the reason I told you we should not be discussing that on this platform, because it's an illegal way of it's not legalized. So you will find people from Roche and even this ibrutinib guys looking for people who are making this drug available. So we stay out of it. I think the patient gets it. And I think 100 mg is the lowest strength they have. That is what I know. So I have.
There are some starter packs available, Venclexa. So they have different strengths.
So original innovator has it, but I have never used an innovator, because as you said, innovator can be available. There are many people from Mumbai who are doing this. You will get any drug in the world. You just need to pay them. They will do everything for you. But no patient on innovator, maybe sir, and you have used it. So there must be 20 in innovator. Obviously that is what they suggest, but we have used 100 in our clinical setting in Ahmedabad. That is the lowest available strength we have.
Sure. I agree with you. There are 100 types of expenses, so if the patient can save. There are patients who insist on innovator, so that's all right, because they are belonging to that group of Adani, Ambani, so that's all right. But that's what, on fingertips, 1-2 patients in the whole year, you get those kind of patients. There are some raise hand signs. Ashok, Kajal, do you have more questions? If not, then we will move to the...
So no questions.
Yes.
No questions, sir.
No question. We'll move to the question.
Thank you.
Box. Thank you.
Thank you.
Dr. Tejaswini wants to know, Doctor, how frequent is neutropenia in CLL patient when you're using venetoclax.
So at least half of the patient, more than half of the patient would develop a neutropenia. If you go by the traditional protocol that we follow, but as sir said, if you go by that antifungal plus voriconazole, posaconazole with venetoclax, it is maybe a smoother ride. But the traditional dose ramp up 100, 200, 400, you generally tend to have more than half of the patients. I think literature also suggests that more than 50% of patients do land up into neutropenia and you'll have to stop the drug.
Right. It's extremely common. Abhishek, one more question. Mohammad Hussain Mir wants to know. If you have 11-14 translocation positive myeloma, you will use venetoclax in second line, third line, or beyond?
So if I can use it, so I think 1 to 3 lines and beyond. The original trial had used at least people who had relapsed on 3 previous regimes, 1 to 3 previous regime. So second line, third line, you could use it in both settings.
Right. The next part of the question he has is about the use of venetoclax in relapsed, very high grade DLBCL and in patients who have registered transformation.
So if you remember in my last talk about 6 months back, I had presented data on targeted treatments in high-grade lymphomas where there was a few trials with ibrutinib, venetoclax, steroid and rituximab in high-grade relapsed lymphomas where there is nothing else left to be done. And they had shown excellent CRs and responses. Couple of patients, we did use it clinically also, but believe me, nothing worked. So I don't know. There is data that you could use it, but it is all phase 2 data. There is no phase 3 data. The phase 3 trial which they did in the first line setting, that failed.
Right. So those are the 2 questions from him. Chat box, there is nothing. Fine. So I think that brings us to the end of all the questions. If anybody wants to comment or ask any more questions to Abhishek Kakru, go ahead.
Sir, I have a question. Sir, in case of cytopenias, if the patient is already in remission, an AML patient already in remission, while on venetoclax and azacitidine, if the patient develops a cytopenia, maybe the neutropenia, how can we be sure that it is because of the drug and not because of the relapse of the disease? Should we go for a bone marrow every time when the patient develops cytopenias without blast in the peripheral blood?
So I think the recommendation is quite clear. If you develop a grade 3-4 neutropenia, you stop. You probably use a GCSF if you want. And even if after doing that for a week or so, maybe a couple of weeks, it does not recover, there is the time when you rethink your strategy. But immediately, I don't think you should be looking to do a marrow in a patient who is on venetoclax because you are expecting these things to happen and you treat them. Most patients would recover.
Okay.
It does not recover, then obviously you are looking at something else.
Okay. Thank you.
Thank you. So Abhishek, extremely grateful to you for wonderful presentation. It requires a lot of hard work to put up this kind of presentation, which is very comprehensive, to the point, very educative. I'm sure, forget the students, but even the seniors, everybody learned a lot today, can fine tune their practice and use this molecule very efficiently. And credit to you. And thank you so much for accepting the invitation to spare your time. It requires 2 months of preparation to ultimately give a talk. And you did that excellently. And thanks to all the discussants for wonderful questions and sparing your time to join us. Thanks to the sponsors, RPG. And finally, thanks to Yash and Kalpesh for flawless management of our webinars. Wonderful lunch at your home with your family.
As you said, it took a month or so to prepare this, and what I did is I basically angered Sanket, who was looking for me to present a lecture in the next Saturday Sunday conference. So he went after me. You have to take a lecture. I have to take a lecture, but I told him I can't because if the 2 lectures mix, I'll be nowhere because it's too close to this one. So the person who was most frustrated with me was Sanket.
Also, thank your family to allow you to prepare all this.
So Shivani is more than happy. She knows you. You have worked with her. She's more than happy with whatever I do. on this platform, because many a times on Sundays and Saturdays we are on this lecture. So it happened a lot during the COVID time. So sometimes she used to get frustrated, but not every time.
It gives her more privacy. Good. Thank you. Bye-bye then, everybody. Bye.
Thank you, sir.